Bismillahirrahmanirrahim. First of all, I would like to congratulate SSBMT for a great conference. I'd like to thank the organizers and Johnson & Johnson for the invitation. So my topic is the role of Daratumumab in shaping current and future management. So hopefully I'll finish in less than 30 minutes. These are my disclosures. Okay. So we have come a long way in the treatment of newly diagnosed multiple myeloma. For transplant ineligible, we used to treat initially with melphalan, prednisolone, then we got MPT, then RD, VRD, VMP, and VRD, more recently quadruplets, DARA VMP and DARA VRD or ISA VRD. In transplant eligible patients, we used to give, if you remember, 2 decades ago, VAD-like regimens, and then we had thalidomide, then VRD, and now we're getting quadruplets, DARA VRD. Before I dwell into the role of daratumumab in various settings, I just want to highlight one aspect that is MRD and its impact on outcomes in the patients with multiple myeloma. This is a meta-analysis by Nikhil Munshi and team looking at more than 8,000 patients, 93 publications on the outcomes with achieving deeper MRDs. You can see here, if you achieve deeper MRD, irrespective of the case, transplant eligible, ineligible, or relapse refractory, your PFS and overall survival is better. Irrespective of how deep you achieve the MRD negativity, again, the PFS and overall survival in all these group of patients are significantly better with a hazard ratio ranging from 0.38 to 0.5. And you can see the 2 curves here separating so beautifully in transplant eligible patients who are MRD negative. And another question is achieving MRD negative once, is it enough, or do we need to have sustained MRD negativity? This trial looked at this. You can see the blue line, the PFS in patients who achieved persistent MRD negativity, the red line who are MRD positive. You have another green line in between. The red line in the lower graph is those who achieved MRD negativity but lost it. So it is very important, these patients, to achieve deeper and persistent MRD negativity if you want to have better results. And this is from the Cassiopeia trial. Again, those who achieved MRD negativity at the end of transplant, nearly at 12 months, you can see their curve. The PFS is almost at 90% or more. Again, this master trial looked at MRD at various time points with a view to stop treatment if MRD negative on 2 occasions. Again, you could see those who achieve sustained MRD negativity, they have their overall PFS and PFS at 18 months is significantly longer. So that means if we just achieve MRD once, that is probably not enough. And important thing is our first shot. Just now, Dr. Richter discussed, Dr. Ayman raised about using quadruplet regimens. Are we exhausting our armamentarium at the beginning itself? It's important to note that our first shot is going to be the best shot. If you look at this study, there's attrition in the number of patients with each line of therapy. In transplant ineligible, there are 50% loss of patients. They're either dying or are not able to get any further treatment. Whereas transplant ineligible, there is lesser attrition, but with each line of therapy, there is significant attrition. So we got to have our best shot, our first shot as a best shot, and especially it probably matters more here in Saudi Arabia and low middle income countries where access to neo drugs and clinical trials is not like in the West. So let me briefly go through the recent approaches with daratumumab in mind in transplant eligible patients. So CD38 is a very critical target in myeloma cells because it is expressed highly by myeloma cells, and it acts as a receptor and adhesion molecule, and it's also expressed by other immune cells, making it a very attractive target in these patients. So coming to the Cassiopeia study, the large randomized phase 3 trial in newly diagnosed multiple myeloma patients who are transplant eligible, compared DARA VTD versus VTD, and consolidation maintenance was only DARA monotherapy versus observation, because And lenalidomide was not approved at that time in 2015 when this trial started in Europe. And you can see very good deep responses. 65% VGPR are better compared to 56% in the VTD arm. And even in the MRD at 10 power minus 5 by flow, 64% versus 44%. And you can see the benefit across all groups, including ISS3 and high-risk cytogenetics. Again, we saw this graph with persistent MRD negativity. Your PFS is close to over 90%. So this is the updated PFS. Median is 83 months at a median follow-up of 80 months from the first randomization, which is 2.5 years longer than in the DARA VTD compared to the VTD, 7 years versus 4.5 years. So really, we have made a huge progress in multiple myeloma in the last 2 decades. And again, you can see updated overall survival. It's significantly, the hazard ratio 0.55. So you increase the risk, decrease the risk of death or progression by 45% versus VTD. So this is the DARA VRD that we more commonly use because we don't use thalidomide in this part of the world. DARA VRD versus RVD is a phase 2 randomized trial. Again, over 200 patients. Induction, consolidation, and the maintenance, you have DARA R versus R up to 2 years. After that, they can continue LEN. Again, you can see very high responses. VGPR and more than VGPR around 85 to 90%. If you remember the olden days of VAD, we used to get a CR rate of 10 to 15% with great difficulty. With a lot of toxicity, infusional regimen, things have significantly improved since then. Again, MRD 51% versus 20%, almost nearly double with the addition of Daratumumab. Again, at 4 years, the PFS is 87% versus 70%, which is remarkable with a hazard ratio of 0.45. And more recently, we have this phase 3 randomized control trial confirming the results of Griffin study presented in ASH last year. And you can see here at 48 months, 84 versus 67%, the PFS, again, remarkable results. It works in all different subgroups, including high-risk cytogenetics. Again, the overall survival is still immature, but there is a trend favoring DARA VRD. So now coming to ESA VRD GMMG HD7, the part 1 of this trial, ESA RVD versus RVD. Here the maintenance they have randomized between ESA R versus R, unlike in Perseus trial. Again, the primary endpoint was MRD. You can see here very high VGPR 77 versus 60%, and MRD rates 50 versus 35%. The first trial with the primary endpoint MRD negativity to achieve this. Again, is it toxic? The quadruplet in Cassiopeia trial during induction, you had no deaths. In Griffin, you had 1% deaths. And in GMG HD7, you had 1.2%, which is not very high. Our supportive care, of course, has definitely improved. Again, this gives us hope that we can use it more confidently. And also over 90% response rates. And again, no significant effect on stem cell collection, and more use of Plerixafor. This master trial used DARA with KRD. Again, is a phase 2 trial. What I want to highlight here is achievement of high MRD negative rates, even in ultra high risk patients with 1 or 2 high risk cytogenetics. So here almost 79% MRD negativity rate, even in patients with ultra high risk myeloma. So this is an area of unmet need. So we know if we achieve deeper MRD responses, your outcomes are going to be better. So this is a very attractive option. You can see here, even with 1 high risk cytogenetics, the results are similar with someone with no high risk cytogenetics, although ultra high risk is not doing as well, but still very excellent results at 2 years. Again, this is another trial that looked at DARA KRD with tandem transplant followed by maintenance in high-risk myeloma patients. The 30-month PFS is 80% in this very hard-to-treat group of patients with high-risk cytogenetics with very deep MRD rates close to 70%. So this is a quadruplet regimen. Dara VRD or ISA VRD is approved even by NCC guidelines, and this has pretty much become the standard of care even in Saudi Arabia, wherever Dara is easily available. So what about coming to briefly about transplant ineligible patients? So this is a trial that established VRD as a standard of care compared to RD. And you can see the PFS 43 versus 30 months and overall survival 75 months. In transplant ineligible patients, just 15 years ago or 18 years ago, the survival was less than 4 years, 3 years. And this really changed the paradigm in this group of patients. Now, with the newer data, I'll show you, and we have done much, we're doing even better. But what is important to note in this trial is those who are over 65 did not do well. Their PFS is still around 30 months, even with VRD. So this was a kind of unmet need because this trial included both under 65, over 65, with not with an immediate intent to transplant, but they could transplant later. So this Alcyone study that compared VMP with Dara VMP, because this was the one approved in Europe, first quadruplet phase 3 trial, and it showed, you can see clearly the PFS and overall survival in favor of Dara VMP with 30% reduction in the risk of death compared to VMP. The median PFS was 37 months, better than VMP, but still we could do better. And now we got the Maya study, which everyone knows, DRD versus RD in transplant ineligible patients. What is important to note here is nearly 80% of the patients were over the age of 70 years. So these are really, we're talking about older age group, even though the older age and older people in the West, we cannot directly compare to our people. They are more fitter, and around 15% of the patients had high-risk cytogenetics. You can clearly see the median PFS is 61 months compared to 34 months in RD. So really, it has established a benchmark or a standard. So see where we used, the survival was 3 years, just 15 years ago, and now the PFS itself is 61 months. So we have really come a long way in the last 15 years. Again, patients with one high-risk cytogenetics, they do reasonably okay, but not with two high-risk cytogenetics, even though the number of patients enrolled in this study were only 15% who were high-risk cytogenetics. And patients who are less than 70 are doing much better, but 70 to 75 are as well doing reasonably okay compared to RD. And you can see their PFS is still around 60 months. Again, overall survival is trying to show that patients are tolerating, and we can see the effects even in the older subgroup population with this Dara-RD. And it is equally good in most of the subgroups. And we have the 7-year update of the survival. Now it's reaching up to 7.5 years, so almost 80, 90 months. So that's remarkable achievement in these elderly infirm patients. So coming to the IMROSE trial, ISA VRD versus VRD in transplant-eligible patients. So we're moving from triplet to quadruplets, even in transplant-eligible patients. Again, similar. So basically, you're giving Velcade for up to 9 cycles, 6 months, 24 weeks of therapy. It's not you're continuously giving Velcade. So you're giving for the first around, say, 9 cycles, and then you take off Velcade out of the equation. Again, really the excellent results. 60-month progression-free survival is 63.2. Median PFS is not reached, so I think it is going to beat Dara-RD. But what is important to note here is VRD is also doing very well with a PFS of 54 months. I think it is maybe our supportive care has improved. I think it is still reasonable standard of care in low middle income countries. If they don't have access to Dara, I don't think they should feel bad, or ISA. Again, overall survival, there's a trend towards ISA VRD. Coming to the CEPHEUS study, most recently, it was presented in the International Myeloma Society in Brazil by Saad Usmani. Subcutaneous Dara with VRD like we use here. So here, the difference is it not only transplant ineligible, but transplant deferred patients were also included. And this trial was done during the COVID pandemic also. So we need to keep that in mind. So there were around 15% of the patients high-risk cytogenetics, and you can see high MRD negative rates, 60% versus 40%, and the CR rates 81% versus 60. If I told you 15% CR, which was hard to achieve with VAD, now we are seeing 81% CR, which is really remarkable. And again, your MRD negativity, deeper MRD responses even at 10 power minus 6, and also at 12 months sustained MRD negativity. And the numbers are almost double. Adding DARA has doubled the numbers. And 54-month PFS is 68% median. We have not reached. I think it's probably going to be 75 months or 80 months. And VRD again doing very well with 52 months. It was effective in all subgroups, and there was a trend. But if you censor for COVID deaths, I think it was even better with DARA VRD. Again, safety-wise, of course, more cytopenia, thrombocytopenia, you would expect with DARA VRD, but we know how to manage, and otherwise there was no other concerns. The benefit trial, ESA RD versus ESA VRD versus ESA RD. Again, here transplant eligible patients were only included. Again, the primary endpoint was MRD negativity. You can see almost double the rates at 18 months, 53 versus 26%. So deeper responses, significant even at 10 power minus 5 and minus 6. Really very impressive results. The survival data is still not released. I mean, the PFS and survival. So we are having newer trials that are looking at adding bispecific antibodies in the front line, teclistamab and alantamab. So it will be interesting to see the results. Finally, briefly coming to the maintenance. So this is a meta-analysis that established lenalidomide as the maintenance, giving nearly 2.5 to 3 years improvement in PFS and OS. And again, this study made us use bortezomib in 17p state negative patients, but we generally use dual maintenance with Velcade and lenalidomide in this group of patients. Cassiopeia, as I mentioned, with DARA VTD or VTD DARA, you have maintenance, significant improvement in progression-free survival and overall survival, although this practice is not very relevant to us because in this trial, lenalidomide was not used. And it's important to remember that the patients who benefit most are standard risk patients. We always think to or focus on high-risk patients. In this Canadian study, the survival with standard risk patient was 13.5 years with len maintenance, and in high risk 7 years. So definitely an area of unmet need. So this is an Origo study that was presented again last month in International Myeloma Society that basically included all the patients after they received induction and transplant. They should not have received daratumumab. Whoever was MRD positive, more than 10 power minus 5, was randomized to DR versus R. So this is a question everybody asks, whether we should give DR or R alone. And they looked at various points. Again, high-risk cytogenetics were almost 23% higher in the DR group compared to R group. Otherwise, they were equally matched. 25% high-risk ISS3. You can see here clearly the addition of DARA to R doubled the MRD negative rates at 12 months. And even if you look at the patients who are achieving CR at any time, 25 versus 61, and so clearly double, close to triple in the primary endpoints. And again, even performing very well in high-risk cytogenetic patients with regards to achieving deeper MRD negative states. And it also increased the conversion rates, MRD conversion rates compared to R alone. You can see 50 versus 18%, nearly tripled. Very impressive results, honestly, and at 12 months and 18 months. Again, this is MRD negative. 10 power minus 6 conversion rates at 12 months was also superior, including the CR rates were higher conversions in the DARA-R arm. at PFS at 30 months was 82 versus 66%. So nearly 20 percentage points difference, and really favoring DARA-R. And even if you look, those who achieved MRD negative, if you look at their PFS, almost a straight line, and impressive results here. And there were no new safety concerns. It was reasonably well tolerated, because we all have experience using DARA-R in transplant-eligible patients. Usually most patients don't have to stop the treatment. So this is another study that is by SWOG, randomizing between DARA, LEN, and LEN. So I think we'll know more about adding DARA to lenalidomide when this study will be presented. Phase 3 study, MRD guided. And again, MGHD7, they are randomizing ESA-R versus R. So 3 years follow-up. So this will all be interesting to see the results. Adding CD38 monoclonal antibody, how it's going to improve the outcome. And again, this is another study as well, DARA-R versus R in maintenance setting, also looking at the MRD-based approach. So key learning points. Quadruplets have become pretty much the standard of care in transplant-eligible patients, offering us to achieve deeper MRD responses. And we know that is going to translate into better PFS and overall survival. And Perseus, Griffin definitely have demonstrated that benefit. And for transplant eligible, DARA-RD is still the standard of care, but quadruplets are challenging. And especially, I believe there will be a certain group of patients who are borderline for transplant or no transplant. They could benefit, but I wouldn't be surprised if everyone starts using quadruplets in the near future, given the excellent data. And adding monoclonal CD38 antibodies to lenalidomide further improve the outcomes in transplant-eligible patients. With that, I thank for your patient listening. Thank you.